It's a pandemic that has changed the world as we know it. 16.9 crore people and counting have been affected by COVID-19 virus. There have been 35.27 lakh deaths so far. Is there any light at the end of a dark tunnel? Welcome to this week's Doctors Roundtable that is going global today as we look at various models from across the world in containing the pandemic. On this unique Doctors Roundtable, please welcome guests from across the country. Dr. Mohammad Rafiq is a medical director, specialist pulmonology at the Prime Hospital in Dubai. I'm joined also by Dr. Shankara Chetty, medical practitioner treating COVID-19 patients in Port Edward, South Africa. Dr. Manish Gautam is Deputy Director, Liverpool University Hospitals in London. Dr. Kritika Kupali is Infectious Disease Specialist, South Carolina in the United States. And I'm also joined by Dr. Ambrish Sathwik, vascular surgeon at the Sir Gangaram Hospital in the National Capital. Thank you all very much for joining us. I'm going to go issue by issue to get a sense of a global perspective today, questions that are most frequently asked. And I want to start with you all with this question. What is the best way to contain the pandemic, lockdown or vaccines from your experience in your country? I want to start with you, doctor, there in America, because Dr. Kupali, we've seen that the US seems to be ahead of the curve, whether it's in vaccinations, 40% of the population vaccinated, or indeed in lifting restrictions, more and more restrictions being lifted. Tell us what's the way forward, lockdown or vaccinations in your view?
Yeah, that's a really wonderful question. So I think that it's a combination of things. I think first and foremost, you have to stop ongoing transmission. And as we know in India right now, the rates of transmission are still extremely high. And so one of the ways you do that is by having potentially targeted lockdowns in areas where we're seeing rates of transmission high. The other thing to do is also to really reinforce these non-pharmaceutical interventions. So things like wearing masks, maintaining physical distance, trying to abstain from large crowds of people outside of your home, and also maintaining good hygiene. And then I think the other part of that is also trying to scale up a vaccine campaign. So I think that as we've seen, not just in the United States, but Israel, places that have been able to vaccinate quickly, we've seen case numbers come down. So I think it's a combination of all these things.
You're saying it's a combination, but would you say that the key factor in the United States success, if I may use the word, in the last few months has been vaccination? That the faster and the more you vaccinate, that really is critical, even more than having lockdowns?
Well, so yes, vaccination is extremely important, but when you're in a surge, you can't vaccinate your way out of a surge. And so when you're in a situation as we're seeing in India right now, you can't just plan to vaccinate your way out of surge. Remember, it takes a couple weeks to develop antibodies. And so while you're vaccinating, and that's very important, you also have to reinforce these public health measures to prevent ongoing transmission.
Okay. Let me get the experience that from the United Kingdom now. Dr. Manish Gautam, your experience from the United Kingdom, what works? Because the UK is also lifting restrictions at the moment. I know there have been a sudden rise in cases in the last few days, but the general impression is that your vaccination drive has also been very aggressive. So is it an aggressive vaccination drive that is key to containing the pandemic, or is it an effective lockdown?
Thanks, Rajdeep. First of all, thank you for putting this panel together, where I'm actually talking to intellectuals. So it's really helpful. Any sort of intellectual conversation on COVID is the need of the hour. So coming to the UK strategy, we got things wrong here in the beginning. The lockdown was not implemented at an earlier stage. Obviously, that did have some negative repercussions. But I guess the most important thing in this situation of COVID-19 pandemic is learning from mistakes. And I think one of the things UK has done reasonably well, learn from mistakes which were done at the beginning of the pandemic. When we came across second wave and the third wave, all the mortality was high because the virus was more virulent, but we were able to manage our day-to-day operational side of things in hospitals in a much better way. And what obviously has helped the UK in keeping things under control is massive drive on vaccination. And I say it's one way to control pandemic. Well, I think the only way to control pandemic is trusting your academics. So that's what has happened. UK relied on research, led from front in the area of vaccines, and massive drive has actually helped to keep things under control. However, with the arrival of the strain which originated in India, we are seeing increased number of cases here. Therefore, the UK government has tried to speed up the second vaccination dose.
I'm going to come.
And also, we're reviewing the opening of full lockdown in 3 or 4 weeks' time. That potentially can get delayed. But overall, we're in a much better state than we could have been.
I'm going to come to whether, so there are certain strains of this virus that escape vaccines, because that's an important element. I'll come to that in a moment. But let me first get initial comments on that critical question that I'm asking on what's the best way to contain the pandemic from your individual country experiences. Dr. Shankara Chetty, you're a medical practitioner there in South Africa. And South Africa, interestingly, has not been vaccinating because one of the strains, the so-called South African strain, has apparently escaped some of the vaccines. So is vaccination really the solution as there are more variants and more mutants out there? Or is it having strict enforceable lockdowns? Are lockdowns really very temporary solutions because the virus keeps evolving?
Well, in South Africa, our vaccination campaign has been very slow to take off. And of course, the vaccines have shown that they're not really effective against our strain here in South Africa. But we got to be cautious about vaccinating, in that we found in South Africa in the first wave, the lockdowns applied to a certain section of the population. So you've got to look at the kind of population you're dealing with. We had very hard lockdowns in the first wave, but this didn't apply to the lower socioeconomic group of our population, who live in informal settlements and don't have the means to isolate from each other. So we had the virus spread rampantly amongst the lower socioeconomic groups in the first wave of the pandemic. In the second wave, vaccines started to roll out. But what we found was that the blood services did a survey and found that a large percentage of our Black population had developed herd immunity. Now, research is coming out showing that the immunity from infection seems to be long-lasting. So I think we need to re-look at the vaccines and consider whether we should be vaccinating those that have developed immunity and reserve them for those that haven't had that immunity. So the vaccines haven't really prevented us getting infected. They've basically managed to prevent severe infection, severe illness.
So are you saying that the South African example suggests that there is the possibility of herd immunity emerging and vaccines at best can be used to check deaths and fatalities, not so much the pandemic?
Yes. I think as the variants change, we're still going to get breakthrough infections, even in countries that have had mass vaccination campaigns very effectively. So herd immunity comes from infections. We've seen that mild infections tend to develop good immunity. And until we investigate this in that light, vaccines on a large scale are not going to develop the herd immunity that we want. There's going to be breakthrough infections with different strains.
Very interesting. That's a very different perspective coming in there from South Africa, a country that is vaccinated less than India at the moment, but where herd immunity, according to Dr. Chetty, appears to slowly be setting in. I want to come to the UAE. This is a country, of course, much smaller, but with a very varied population. Large numbers of people come in and out of the United Arab Emirates. It's a gateway in a way to several countries. Dr. Mohammad Rafiq, your experience, how has the UAE dealt with it? I know there's a basket of vaccines out there. I know friends who've double vaccinated and are even looking forward to a booster in 6 months. So is the UAE experience vaccinate above all else?
Good evening, Raj. Our experience has been pretty much positive when it comes to vaccination. And we could really see the difference after this vaccination drives really kicked off. And I think you're very much aware that it is one of the highest rates globally on the vaccination curve. We're talking about 128 doses per 100 person. And this has definitely made an impact in the form of diseases, especially the severity of the disease, which we see. We don't see much of moderate to severe cases compared to what we used to have before these vaccination drives kicked in.
And correct me if I'm wrong, doctor. You opened up after you had vaccinated a substantial section of your population. Am I correct?
Yes, we did open up, yeah, and we did have a significant percentage of the population got vaccinated. You're right. And later we started having a host of, the government took a lot of good initiatives to bring in a variety of vaccination available. So, and it is free of cost. And there was now most of the events, most of the functions, if you want to attend, it is important that they get vaccinated, and people who are vaccinated are given an entry and pass. So that's the way forward. And definitely we are seeing good results and amazing.
And all vaccinations were free? All vaccinations were free, whether it was the Chinese vaccine, the Pfizer vaccine, all vaccinations were given free to citizens?
Yes, that was an excellent initiative from the UAE government, irrespective of it's for the all population. It is free of cost,
right?
For everybody, irrespective of where they come from, and that has definitely made a big impact. We find everyone gets vaccinated, and the awareness is very high. That's what I would say.
Okay,
a lot of awareness when the patients who come in, because the public, they are aware about the concept of vaccination, and there are primary health centers, there are camps, vaccination booths. All these are pretty much available, and it's very easy to book these appointments.
Interesting what you're saying.
You can select the choice of vaccine also. Like you
can select the choice of vaccine. It was free of cost, and it was effectively communicated. Dr. Ambrish Sathwik, and this is a question related. Is the world therefore now divided between the vaccine-rich and the vaccine-deficient countries? India is a leading vaccine manufacturer, but we've struggled to meet up with the sheer demand on vaccines, while the US at the moment seems to have a surplus of vaccines. Do you see that as a concern as going ahead, a world divided between vaccine-rich and vaccine-deficient countries, Dr. Sathwik?
Yes, thank you. Yes, we are where we are, and we've managed to vaccinate about 3% of our population. We have a long way to go. Now, we have to find solutions with whatever we have. And what we saw with the second wave was a very steep exponential growth. And also now what we're seeing is an exponential decay. So the cases are falling quite rapidly. But we have a large majority of our population which is unvaccinated, which might also be naive to the virus, which is vulnerable and susceptible. So we have to find our own solutions. And my recommendations here would be that I don't think we are testing nearly as much as we should be. Because, on the 11th of May, Dr. Balram Bhargav had a press briefing where he said that, our daily testing capacity is roughly 3.3 million tests, okay, about 16 lakh RT-PCRs and 17 lakh rapid antigen tests. And the maximum we have ever tested in a day is roughly 2.3 million. So we're not even utilizing our full testing capacity. If you're not testing enough, you're missing a lot of cases. These cases are going around and they're spreading the virus in the community. But my recommendation is to look at the problem from a slightly different perspective. You have a test which is considered to be the gold standard, which is the RT-PCR. But the trouble with this is that it's expensive, it can't be scaled up, it requires a lot of expertise and accredited laboratories, and it has a fairly long turnaround time. What if, particularly when we are unlocking, what if you had a test that was cheap, let's say 50 rupees or 60 rupees, was a self-administered test that you could carry out at home. You get the report in 15 to 30 minutes, and what it told you very effectively and consistently was whether there was virus in your nose and throat in a quantum that would be infectious to others. That's all it tells you. If you're positive, you're infected, you stay at home. If you're negative, you can confidently step out and go to your workplace, or perhaps go to a restaurant, and that will give you the confidence to actually unlock. But this test has to be repeated with a very high frequency, perhaps 3 times a week or every other day or sometimes every day. And this test is available to us. This is the rapid antigen test. With our scales of economizing, you can actually bring down the cost of this test to as much as 50 to 60 rupees. And you know, from a public health perspective, this is the test that is going to drive the R number, the reproductive number of the virus, under 1 and very quickly identify outbreaks.
But Dr. Satwik, if I may just stop you for a moment, is it not true that this test is, its sort of efficacy is under question, whether it effectively picks up the virus? And more importantly, isn't the real challenge for India to reach 90 lakhs vaccinations per day, so that by December 2021, end of the year, we can reach the ostensible target of 2.1 billion doses? Shouldn't that be the sole focus rather than testing?
There isn't a conflict. I don't think, you know, vaccination will carry on at its own pace and needs to be expedited. But as regards your question on how sensitive this test is, this is not a very sensitive test to diagnose an infection throughout the course of the COVID-19 disease. Right. But it's a very sensitive test to diagnose contagiousness, to diagnose infectiousness. So the important thing is, whenever someone is symptomatic, they're obviously isolated, they're masking themselves, they're sequestering themselves, they're not stepping out. But a person is most infectious to others 1 to 2 days before they develop symptoms. At that point, they're completely asymptomatic. Right. And this test is fairly sensitive in picking up the viral load when the person is shedding the virus. It's a test of infectiousness. It is not necessarily a gold standard test for infection. So it's very, very effective. Think about it. You're opening up, you wish to go to a restaurant. If it becomes mandatory for you to take the rapid antigen test, you get the report in 15 to 30 minutes. It's a self-administered test. Right. You'll make sure that, you know, whenever you're partaking of high-risk behavior, you'll be confident. The restaurant owner can mandate this test for the serving staff. Okay. So you'll be confident you won't catch the infection there.
Okay, so I think what you're saying is that this is another element in this fight that you cannot ignore here. I just want to get a quick answer to this question. Will the new mutants escape vaccines? I want to understand this because across the world, and Britain is a good example at the moment, Dr. Gautam, where there is a fear that the B1617.2 vaccine, the so-called vaccine emerging from India, could be escaping some of the vaccines, or at least the antibodies may be escaping the vaccine. Is that a fear that we have? Some Nobel laureates are also warning about this. Do you fear that as the vaccine, as the virus mutates, some vaccines may not be effective with them?
It's a very good question, Rajdeep, and unfortunately, no one actually knows the answer for sure. But saying that, as you suggested earlier, a number of cases we have identified in the UK as well of the same variant. And the recent study conducted has suggested if you had one vaccine, it actually doesn't protect you much against the variant. So that's a study conducted on the Indian variant in the UK, so which is conducted in the last few weeks. However, if you have 2 doses of vaccines, so if you have Pfizer vaccine that gives effectiveness of up to 88%, whereas AstraZeneca gives protection of up to 60%. So it's going to put significant challenges for the reopening of lockdown strategy in the UK. But at least we have some protection with vaccine, and it's not escaping the vaccine completely. So that is the reassuring thing. And therefore, the government has massively scaled up the drive to have 2 doses.
The sense, therefore, I get is, except for South Africa, broadly at the moment, most of you at least seem to suggest that the vaccines at least work against ensuring against serious illness or hospitalization. Broadly, that seems to be the consensus at the moment across the world, really, even though we don't know what the future will hold with new mutants. Let's come to another contentious question. I want to get each of you on this with short answers to explain the concern that the world has. Is there a line of treatment that's actually working for COVID-19? Dr. Kupali, you're an infectious disease specialist there in America. Is there a clear line of treatment? Because the US, for example, was recommending at times remdesivir. The WHO wasn't. Is there a clear line of treatment in the United States?
Sure. So, yes, remdesivir is approved here in the United States for treatment, but I think the thing that people need to understand is remdesivir has been shown just to decrease your length of stay in the hospital. It has not been shown to improve morbidity or mortality. I think the only thing that's really been shown to be helpful in people who have COVID has been steroids, right? So in the recovery trial, they showed quite profoundly that people who get dexamethasone 6 milligrams a day for 10 days, that especially if they're on oxygen, that can help with their long-term morbidity, mortality from COVID. But in regards to some of these other medications that we keep hearing about, things like ivermectin, hydroxychloroquine, tocilizumab, there really is not a lot of good data out there to suggest that they help in patients.
So
who
are
have
US
COVID.
doctors, let me get that correct, are US doctors saying no to ivermectin, to toxizumab? Are you all saying no to that? You would not use that? Most doctors in the US would say no to that?
We are not using ivermectin at all. We are not using hydroxychloroquine at all. I think in some cases where patients may be very, very, very sick, they may consider using tocilizumab, but that is it. We are not using, I've heard all sorts of different medicines like Flavifu and all sorts of different medicines in India, and we are not using those medicines here. There's no data to support that we should be using those medicines.
Okay, let me go to South Africa. Dr. Chetty, is there a line of treatment that is being recommended for COVID patients? You've been dealing with a number of them.
Look, in South Africa, the general medical fraternity has been using the World Health Organization protocols to treat coronavirus. I've been doing a lot of research around coronavirus, and it's come to light that we're dealing with a biphasic illness. We found that on the 8th day, there's a switch in the way this disease progresses. We found a lot of patients by the 7th day recover from the viral illness. And on the 8th day, there's a trigger of hypersensitivity. So from that perspective, there's a lot of research around the world that has shown that this is true. There is a bit of contention about the type of hypersensitivity on that 8th day, but the protocols that I've used in treating my patients has been based around the recognition of a hypersensitivity reaction. And I found some remarkable results. South Africa is actually now looking to do clinical trials on what I've found. And we found some very great benefit in starting steroids on that 8th day, seeing that it is a destructive immune response from that day onwards. Antihistamines have now shown to have some great benefit. We've had patients with oxygen sats that have raised quite significantly when putting them on antihistamines from the 8th day onwards. Other drugs that have shown benefit are montelukast and, of course, the anticoagulants, because we are aware of all the clots with this. However, this research is now, the research has lent credibility to this theory. South Africa is starting to do clinical trials. We've been having some great results with this kind of modality.
So correct me, but something very significant, Dr. Chetty. You're saying from 8th day onwards, you're using steroids. You're going by the WHO protocols. No plasma therapy in South Africa?
Look, plasma therapy and the such is still mainstream in the government hospitals. The treatment that I'm using is very novel. I've been doing it now for a year. It has been used by different doctors around the world and shown to be of benefit. A few South African doctors have tried it recently and have found it to be remarkable. So some of the associations have asked for clinical studies trials to be done on it so that we can get the data together and start to change protocols as to how we deal with this illness.
Any particular steroid? Any particular steroid, Dr. Chetty? Any particular steroid that you use?
Look, in my practice, I found that prednisone seems to be the best. Methylprednisolone a little less effective, but dexamethasone not as effective as the other two. But it's vitally important to make sure we start the dose of steroids on that 8th day and not impact on the first 7 days where we want a good, robust immunity to give us immunity to the virus itself. But after the 8th day, the immune response is destructive and we need to suppress it. And that's where steroids play a vital role. However, the hypersensitivity also needs to be addressed with antihistamines and montelukast. And those are the two drugs that we've seen have provided us the greatest benefit.
Dr. Rafiq, in UAE, any recommended line of treatment? Do you all at all recommend plasma therapy, which has now been pulled off, of course, the Indian protocol, but for a while was being used? Remdesivir, any specific drugs that you all recommend?
Yeah, actually, the UAE experience has been, we are very much using corticosteroids, preferably dexamethasone, and then we do use, in selected cases, methylprednisolone right from the beginning, especially in cases which land up with pneumonia, moderate to moderate disease. We don't wait for, we start from the beginning itself. And then, of course, Avigan, which is favipiravir, plays a very important role, and we have got excellent results with this molecule. Of course, anticoagulation is there. Then remdesivir we do use, but for selected cases, of course, going into the moderate severity with oxygenation issues. And we have found good results with tocilizumab in selected cases, especially those patients which are going in for the cytokine storm, and where we did get beautiful results. And coming to your question on plasma therapy, plasma therapy was, of course, tried initially, but then now they found it was not that great, and we are not doing that anymore.
Interesting what we are seeing from the different lines of treatment, but a common theme seems to be the use of steroids. But Dr. Satwik, in India, that has become contentious, the excessive use of steroids, plus the confusion over which medicines to use. Do you believe the time has come for a clearer line of treatment, Dr. Satwik?
Well, a clearer line of treatment has been established both by the ICMR and the Ministry of Health and Family Welfare. There is a very clear-cut schematic algorithm that has been prescribed by the Ministry of Health and Family Welfare, and which is in line with WHO recommendations and the findings of the recovery trial. What I find the only discrepancy here is that, we got the results of the Solidarity trial, which established that remdesivir, hydroxychloroquine, and some other antivirals like lopinavir and interferon beta did not offer any mortality benefits, but still remdesivir is on the ICMR guidelines as an off-label use to stop viral replication. But otherwise, we seem to have fairly wide-ranging consensus of what to do in case of moderate and severe COVID. A lot of our private practitioners and physicians tend to use antivirals in the first week. There are some societal guidelines, but there isn't any clear evidence that these antivirals in the first week are making any great difference. We tend to follow evidence that was established in the recovery trial.
Okay, let's come to a question which in India has a very different meaning to the rest of the world, possibly. The post-COVID challenges that are being faced. We've seen now black fungus cases in several instances in this country. Along with that, what are the shortages that countries have faced at the peak of the wave? Do you want to tell us there in the United States, did you at any stage, Dr. Kupali, face in the United States oxygen shortages or indeed cases where post-COVID challenges are being faced by patients, the so-called long tail of COVID?
Yeah, that's a good question. So I definitely have seen a lot of patients who have this post-COVID syndrome. So, anywhere from a few months out to now, a year out.
No, so what kind of post-COVID syndrome?
Yeah, so they come in with persistent pulmonary symptoms, so shortness of breath, have elevated heart rate, neurocognitive dysfunction, so they feel like they have a quote-unquote brain fog. Those tend to be the most common symptoms that I see. And so trying to understand, first of all, why they have it, and then secondly, trying to help support them through it. And so for some people, it's not very disturbing, but for some people, it can be very difficult, and particularly people who are very high functioning in their profession beforehand. And so I think there's a lot we still need to learn about how COVID affects people's bodies in the short term, medium term, and long term. And then, to the point of, the different infections we're seeing in patients, the fact that we're seeing these very high and disturbing amounts of cases of mucor in India, why are we seeing that? I don't suspect it has everything to do with just, diabetes and steroids and the fungal spores. My suspicion is there's something else going on there. And so, also understanding what's causing some of these problems that we're seeing pop up in other parts of the world.
Dr. Manish Gautam, have you had faced patients who've had post-COVID challenges over the last year as well? And what kind of challenges, very briefly?
Yes, Rajdeep, it's a big challenge for us as well. We do have regional long COVID services set up in different parts of the country. And what we are experiencing is, rather than objective symptoms, low patients are coming back with non-specific symptoms. There seems to be a tsunami of mental health issues, fatigue post-COVID, and the need for rehabilitation. And those are the really important things. And in addition to that, post-COVID era, I can't say we are certainly post-COVID, but the situation we are in, we certainly are struggling with the backlog of known COVID elective work. Okay. There have been thousands and thousands of patients. I said that's something for any government to keep in mind. As we come out of COVID, what's going to hit us badly is the known COVID work. Hundreds and thousands of operations were cancelled, have been delayed. Hundreds of thousands of known COVID medical conditions have been ignored due to various reasons. And that seems to be the biggest challenge for us operationally and thinking from a patient's perspective as well.
Very important point, the non-COVID patients and the challenges they will face. Dr. Shankara Chetty, in South Africa, any evidence of black fungus or any other similar post-COVID ailments?
Look, I think we need to clarify that in South Africa, there are two modalities. I've stepped outside the box and treated patients very differently using a hypersensitivity perspective. I've seen a lot of long COVID cases that I've treated using the same kind of perspective, and I've had good recoveries. Recently, the trials that are being set up to prove what I've done have showed some remarkable recoveries of patients suffering with long post-COVID symptoms. There are instances of patients having post-COVID symptoms for a year that show remarkable recoveries within 3 to 5 days of being treated like an untreated allergic process. So we give them a very short course of steroids. We use antihistamines and again, montelukast. And I've had a lot of patients recover in a very short space of time. This is, however, groundbreaking kind of research. It is showing a lot of benefit to patients.
But are you seeing, Doctor,
it will take a little while for it to become mainstream.
Are you seeing, Doctor, any cases like in India where we've had patients? Of course, black fungus is the most, mucormycosis is the most recent example, but also patients who've suffered cardiac trouble, other ailments. Are you seeing that also with COVID patients in South Africa?
Yes, amongst the general medical community, that has been the case. We haven't seen cases of mucormycosis, but we've had a lot of cases of opportunistic infections due to immunosuppression. The use of steroids has triggered oral candida and those kind of things. But we haven't really seen the long-term complications. In my practice itself, I haven't had those, but in government, we've seen the cardiac issues, we've seen the clotting issues, and the usual that the rest of the world has been exposed to.
Dr. Rafiq, anything specific that you've seen in UAE among your patients once they've been cured of COVID?
Yes, one specific thing which you're seeing in our outpatient department, especially most of these post-COVID complications. And it could be simple, or like shortness of breath, and with poor lung function, and behaving something like an hyperactive airway, like an asthmatic airway. And of course, we put them on inhalers, and they do get better. This is one category of patients. Then there's other category of patients who are at home and who are on home quarantine. And sometimes they come for a follow-up. We do find an elevated D-dimer there. And then we go ahead and evaluate them. And a few percentage of them do have some kind of a segmental pulmonary embolism. Okay. These are a very few percentage, what I'm talking about. Right. And then there is another small percentage where they have X-ray issues, like some kind of a fibrosis which develops, and they are being followed up. And the other area is the cardiology issues, which a colleague was speaking about. Post-cardiac issues, post-COVID cardiac issue is something which also needs to be focused on. Like people do have sometimes pericardial effusions, pericarditis, sometimes acute coronary changes.
But none of you seem to have seen what we've seen in India, which is this large sudden emergence of mucormycosis, and that, therefore, Dr. Satwik, is that unique to India? Do you believe we've had a few cases in neighboring Pakistan, but we're still trying to find out why is it that this has happened in India?
We're trying to find out why this is happening. And yesterday, there was a set of regulations issued by the Lieutenant Governor, which expressly forbade any dissemination of information by anyone on the subject of mucormycosis. So, and therefore, I think, other than mucor, what I would like to bring your attention to is something we're seeing as a source of great deal of dread and consternation, which is thrombotic complications in COVID and in the second and third week, even when the patient tests negative. And these are incidences of clotting, both arterial and venous. Venous thrombosis can have its own set of complications, can lead to pulmonary embolism and sudden death, and arterial complications, which are clots that develop in the arterial circulation, can lead to a sudden cutoff of blood supply to a certain part of the body, usually the extremities or the intestines, can cause strokes and heart attacks. And the rough incidence of arterial thrombotic complications in active COVID and immediately in the couple of weeks that follow is roughly 2 to 5% of all hospitalized cases. That's an astonishing number that we're seeing. We're doing almost a couple of cases of arterial thrombosis every day in the institution where I work.
Let me come to getting quick answers to 3 or 4 questions that I want to place because I've got limited time left. Will there be many more waves? When will the pandemic end? The world wants to know this. And I guess doctors cannot be soothsayers beyond a point, but take a shot at it. Do you see a 3rd, 4th wave and several waves as there are more mutations? Why don't you start there in the United States, Dr. Kupali? Do you see many more waves, or do you believe that this will slowly come under control within, let's say, the next 6 months?
Yeah, that's a tough question. I think that the answer to that question is it really lies with us, those of us in the public. If we're
the reason I asked you this in the US, because the impression one gets here is the US believes the worst is over.
So I think some people in the US believe that it's over. I think that there's very much a large part of the United States who also believes that this pandemic isn't over until everybody in the world who wants to be vaccinated is vaccinated, So I think that there's different factions in the United States.
Okay.
And so I think that, again, as we've learned early on in this pandemic and throughout this pandemic, we are all connected, and that infections have no boundaries or barriers. So we can think that it may, quote unquote, be over here in the United States, but if we have surges and waves going on in other parts of the world, those viral variants can very easily reach any other part of the world. And to your answer about whether or not we will see other waves, I think that power lies within us as a society. What are we willing to do to try and help the global population? What are we willing to do to try and help get the surges under control in places, not just India, but Brazil is having a horrible surge right now.
Right.
We're starting to see surges in other parts of Southeast Asia, Nepal, and other parts of Africa. So that answer, in essence, does lie with us and what we are able to do, and we really do need to have a global response.
Dr. Gautam, do you see another wave in the United States, in the United Kingdom, just around the corner?
So, Rajdeep, we already had 3 waves in some part of the UK, and most of the UK had 2 waves. So, I think looking at the pattern, there's going to be more waves. No one wants to hear that, but I think that's the experience we have. And it's a global pandemic. If we are seeing multiple waves, as soon as the lockdown lifts, we see surge in cases. That pattern is perhaps going to continue throughout the world. And the only thing to prevent that, I think to mitigate that risk, is to vaccinate your population as quickly as possible and strict adherence to control measures, which we all have discussed before. Right. But unfortunately, it's going to happen.
So it's going to happen every time you open up. Every time you open up without having fully vaccinated, there will be surges. Dr. Chetty, do you see wave after wave there in South Africa as well?
Look, I think we have a little more hopeful outlook. We've seen that herd immunity is getting developed amongst the Black community who were worst affected in the first wave. So I think the third wave will show a little bit, will be a lot less than the second wave. And at some point, we will have waves upon waves, but we as a community would have developed tolerance and herd immunity. And so I think by the end of the year, we'll see a decrease in cases. We might have coronavirus still with us, but it'll become endemic.
Interesting, Dr. Sathwik, what Dr. Chetty is saying, because in many ways, South Africa would be a lot like India. We saw in India also people who lived in slum pockets in congested areas becoming the worst victims in the first wave. Then it spread to middle-class colonies and new geographies. Do you also believe in the herd immunity theory, that therefore that could eventually result in each wave becoming less virulent than the previous one?
Yes, there seems to be general consensus around that. And herd immunity, which is a combination of both disease-induced herd immunity and vaccine-induced herd immunity. But I completely agree with Dr. Kupali when she says that there are no ecologically sovereign nations anywhere in the world. There aren't any sanctuaries, because the virus is only going to mutate inside the human host cell. It can't mutate on door handles and railings and while it's floating around in air. So as long as there is transmission of the virus, there's an opportunity for the virus to replicate, there is an opportunity to the virus to mutate. So we all get out of this together. As long as there are areas in the world, in every country which are not vaccinated, where people are susceptible, the virus will find an opportunity to replicate and spread and thereby mutate. So the only way of stopping mutations is to vaccinate as many people as quickly as possible.
I've just got 5 minutes left and a few more questions. So quick answers. Are COVID numbers being undercounted across the world? Kupali, Dr. Kupali, in America, have you all undercounted at any stage? Has the data been falsified? Yes or no?
I wouldn't say the data has been falsified, but I definitely do think that the numbers are being undercounted. I think we have many people who have mild infection, who may have asymptomatic infection. And as many people know, early on in the pandemic, it was very difficult to get tested. So I definitely think that we have that problem.
Dr. Gautam, has it been undercounted in the UK as well?
Rajdeep, it started with undercounting in error, but then later on, I think we ended up overcounting the way death was reported.
Dr. Chetty, in South Africa, undercounted deaths, infections?
I think, yes, it's undercounted. I think it's undercounted because of cost. They're counting as well as an unreliable test.
Dr. Rafiq, in the UAE, undercounted?
No, I think here I would say with the extensive contact testing, with the the reporting policies, I would say the numbers which we get are pretty much what is relevant, and I don't think there is an issue of undercounting.
Oh, that's good to hear. Okay, UAE has stuck to the data. Dr. Sathwik, dare I even ask that question to you?
I'll be diplomatic and say that I have it on good authority from experts who are steeped in the discipline of epidemiology that there's been some undercounting, definitely.
By how? Do you want to even hazard by what multiple?
I don't.
Okay. Well, we'll leave it at that we've undercounted. The next question is an interesting one that I have. Which country's COVID model has worked the best? Dr. Kupali, you want to go again? Which country's COVID model has worked the best? Do you have a model out there?
Sure. I'm going to choose two. I'm going to say New Zealand and South Korea for different reasons, but I think those were the two models that I think have worked the best.
Why? Well, what is it about the New Zealand and South Korean model? Very quickly.
Sure. I think New Zealand has been very scientifically based in the way that they managed their response. And then South Korea very quickly learned from the prior coronavirus infections. And so they were able to effectively scale up a response.
Okay. Dr. Gautam, any model that you hold up for to?
So, Rajdeep, very interesting question. And I would say it's a marathon. The race has not finished yet. And therefore, it's difficult to say who the winner is, whose model is better.
Okay, we're not going to...
We have seen completely different outcome from different countries in the last 12 months.
Sure.
So I think we should wait.
Okay, no Olympic medals out there. Dr. Chetty, you want to hold up any global model for the world?
Look, I'd have to agree with Dr. Gautam. The race is not over yet, and we might see a lot more as days pass.
Dr. Rafiq, any model that you feel is the one to follow?
Yeah, as my colleagues were mentioning, I think we need to be pretty much having a lot of surveillance and keep watch. And I'm happy with what the efforts UAE has been doing in this direction. And in fact, they're planning to get 100% vaccinated by the end of this year. So I'd be happy with the model which is presently being followed.
Right.
And as they're mentioning about countries like New Zealand, Israel, Australia, there would be other countries to look into. But as you said, this is something which keeps changing, and we need to be pretty cautious and have all our surveillance and systems in place. Especially air travel is one thing which we need to focus on. Air travel, which requires vaccination passports, where will make a big difference in preventing transmission of infection from one part of the globe to another part of the globe.
Dr. Satwik, any model that you feel is the one that maybe India could embrace? I know we are 1.38 billion, so we are unique in many ways. But is there a model?
So New Zealand is a triumph, but the population of New Zealand is roughly the population of South Delhi and West Delhi. So Singapore...
Not even that, probably.
Not even that. But what is interesting about New Zealand is that they've just vaccinated about roughly 5% of their population. Right. So they're lagging there. But Singapore, indeed, they've managed to, I think, vaccinate roughly a third of their population. They've managed to keep their numbers down, their deaths down, and severe cases down.
Okay. I've got one final question. Was SARS, it's a contentious one. I know a lot of people are debating this. Was SARS-CoV-2 virus made in a lab or not? Dr. Kupali, was it made in a lab according to you? Yes or no?
I don't think we have evidence to show it was made in a lab just yet.
Dr. Gautam?
I think the biggest coronavirus research center happens to be in the same area.
Okay.
So I'll leave it to your interpretations and everyone's interpretation.
Dr. Chetty?
So, no comments.
I have my suspicions. The illness is very unusual. The virus comes from Wuhan, and the lab and the wet market's too close for comfort.
Dr. Satwik?
Well, whatever I know on the subject comes from Nicholas Wade, and well, there's clearly a smoking gun there.
You know, I just have to ask Dr. Kupali, a friend of mine has just sent a question. Antibody cocktail has been given to Donald Trump. It's being launched in India for mild patients. Does the US or any other countries, do you recommend it? An antibody cocktail?
So some of the antibody cocktails, we've found that the Lilly antibody cocktail does not work very well for some of the P1 and the B1351 variant. So you have to make sure that the antibody cocktail will actually be effective against the variants you're seeing.
Okay. You know, it's been fascinating listening to all of you because I think you brought in different perspectives from different parts of the world. And that's the aim that we had. This is a global pandemic, and we all need to work in a cooperative endeavor. National boundaries, in a way, have dissolved, and to get doctors to talk to each other and hopefully learn from each other. There is no one formula, one size fits all, probably no one unique model out there, but clearly a collaborative exercise needed to contain and conquer the pandemic. On that note, to all you five fine minds who've joined me on the Global Doctors Roundtable, thank you so much. Thanks for watching. Bye for now.